Hello everyone, I'm Jeff Walker. Welcome to today's webinar entitled Immaculate Dissection, Taking the Gross Out of Gross Anatomy. Joining me today is Dr. Kathy Dooley, who's the lead instructor of the Immaculate Dissection seminars. She has a ridiculous resume, which includes being an instructor at the Einstein College of Medicine, the New York University. She's a teaching consultant at Cornell Medical College. She's a chiropractor and principal at the Catalyst Sports Center. She's a chiropractor at Moving Body Resources. She's a lead instructor for the Neurokinetic Therapy seminar series. And of course, in her capacity today, she is the lead instructor and founder of Immaculate Dissection seminar series. First, what we're going to do to start off with, I've got a YouTube clip and Kathy's with us. I'll say hello to her in a moment. But I've got this clip and I think it's a good introduction, so we'll just play this.
Hello, Danny here.
Hi, I'm Anna.
Hi, I'm Kathy, and we are Immaculate Dissection. We are the newest seminar series to hit the market, and we are going to teach you some anatomy. As you can see here, the great Danny Quirk has painted Miss Anna here, and he's actually painted the extensor compartment of her forearm. And if you go in close, you can see the details of the musculature. What's amazing about this is that we're going to go over in lecture all of the origin, insertions, innervations, major functional anatomy, but then we're going to actually allow you to palpate and guide you through palpation. The second day of the series is going to involve correctives to actually utilize the anatomy and show you how this anatomy can become important to you and to clients and put it into action. So it's not just listen to people talk like a normal anatomy class. We're going to put the anatomy into functional movement. We're going to take the lab and bring it to you. And so that you don't have to get messy, we're taking the gross out of gross anatomy. Right? With Immaculate Dissection. So we hope you'll join us. If you're a personal trainer, if you are a coach of any sort, if you just want to take anatomy class again with somebody like us, where it's fun and with human movement, we would love to have you with us. Please look at the drdooleyknoted.com website, www.drdooleyknoted.com, and you'll see that scroll across here and where you can sign up. The registration link is attached. Sign up for PayPal, get in the spots because we're only taking a few of you guys. So make sure you get yourself registered. You're going to have an amazing manual with all the anatomy as well as the correction set. So we'll see you hopefully in January. Bye.
See you then.
I couldn't have said it any better myself. Now, some of you wouldn't have got sound with that, so apologise for that. But once we have the replay of this up, we will make sure that you can hear that. It's intriguing. So without further ado, the lady who was the star of that video, Dr. Kathy Dooley, welcome this morning for you, Kathy. Thank you so much for getting up so early.
No problem.
Probably a normal time for you, is it, over there, 4:30 in the morning?
No, not lately. I have been sleeping. I've been a lazy bones and sleeping till about 6 a.m. So.
Oh, goodness gracious. So on that video there, we saw Immaculate Dissection. Now, I guess, who are these people? Who's Danny? Who's Anna? Who's Kathy? How did this all come about? Where did Immaculate Dissection come from?
Oh, that's such a great question. I love answering it. My friend Danny Quirk is an anatomic artist, and how I found him was our mutual friend, Dr. Frank Scally. I met Dr. Scally in chiropractic school when I was just a lowly anatomy tutor, and I remember I was working an evening shift, and Frankie had come in at 10 o'clock at night on a Friday to look at the bodies, and so we had an amazing kinship even back in chiropractic school. And now Frankie is actually going to be moving back to New York to do his residency, but he's planning to be a surgeon. Frankie introduced me to Danny, and we all went to the lab together, and I brought the boys into Einstein, got some permission, and we came in and did some dissection. And the boys watched as I dissected, and they were just fascinated. They really wanted to see a couple of very complicated relationships. Danny collaborated with Dr. Frankie Scally on a couple of papers they published in Clinical Anatomy, and Danny's artwork has been in several publications since. Danny and I became quick friends and decided we needed to collaborate as he started to do these amazing anatomic paintings on the human body. And he uses his own concoction to do it, and it peels right off. It was just amazing, and there's no artwork quite like Danny's, so we decided to teach anatomy in a whole new way. Danny came to see me while I was teaching last summer, and he took my dissection course, And he was just an audit for at a PT school I was teaching at, and I also invited Anna Folkmer, and they both came and did dissections and really enjoyed the process. And so they decided to come on board, and we're going to teach immaculate dissection all over the universe if we can.
And I'm sure you will. I know you have a ton of energy. So, I'm sure you're always looking to do something. So what you're saying there that they're complicated in terms of anatomical terms, that you're looking for some complicated relationships. How would you define that? Or what would you be looking at? What I'd like to do today is just to demonstrate what you know, because I'm right in saying 800 dissections that you've done?
800 plus, yeah. It's probably about, I guess after this semester it'll be about 890, somewhere around that number. I try to math it out every once in a while just because I'm curious, but it should be close to about 890.
So closer to 900 now. Yeah, okay. So the complicated complexes, and as an anatomist, what sort of things do you go in at 10 o'clock on a Friday night to look at?
Oh, that does describe me. If the lab were closer, I probably would be there. The relationships I've looked at on just with myself and my own dissections, I really don't go in looking for something. It usually finds me. And that's what's happened over the course of the last 7 years of my career. I spent a lot of time in the laboratory. I devote a lot of my time to the laboratory. It's around 15, 20 hours a week. And what I started to find were all these connections and relationships, and I started applying them to my clinical situation, finding that, oh my, that explains that, and that's not described well, and maybe I should emphasize this. And I caught it the most when I started talking to patients, or started even talking to my students, and I would make these connections with the anatomy that maybe didn't apply to them as surgeons, but certainly applied to my patients or people that I was mentoring for movement. And I thought, well, nobody is teaching that. Why is no one teaching that? That's important. And I was like, and then someone said to me, why aren't you teaching that? Mm-hmm. And it's such a simple answer. And I was like, oh, yeah, I guess I'd be the one to do that. So I don't know a lot. I mean, I've met a few now that are anatomists, but also movement specialists. Only a very few, like Patrick Cunningham is one that I've met. But there's very few anatomists that are also movement specialists. So I thought, well, I might have a niche here. Let me share some things with the world that might help the manual therapist get even better at their manual therapy skills, help the personal trainer get better connections, anybody involved in movement.
Who thought of the name?
That was actually a blog post that I had done. I was just dissecting one time, and I just called it the Immaculate Dissection, and I was like, wouldn't that be a really cool name for a seminar series for anatomy? And Danny loved it. Danny immediately loved it. So did Anna. So it was just a second thought. It didn't take long at all to come up with that name.
It happens that way, doesn't it?
It does, and mostly because the unfortunate thing in the United States, at least, is that very few people have the honor of human dissection. It's very hard for me to get permission to bring people into the laboratory because it's a very, very special event. People have donated their bodies in order for us to learn at the institutional level, and it's under very high security and also high integrity by me. I am very emphatic about not profiting out of human dissection, that it should be a donation to an institution. And so I thought, well, if I'm not going to promote these dissection courses that are profit-bearing around the world, that I need to actually create a series where I bring the lab to the people. And that is exactly what Immaculate Dissection is. It's the closest thing you're going to get to working with me in the anatomy lab without becoming a med student.
Okay. I mean, one of the questions that I know people want to know is, don't we have enough anatomy courses? Haven't anatomy courses been done to death? What's going to be different about what you're bringing now that you couldn't learn at a more standalone course?
I'm really glad you asked that, because I love that you asked that. First of all, I don't think that people really learn their anatomy in their anatomy classes. Mm-hmm. I think they really only talk about a couple of concentric relationships that they recite from a textbook. They may have some ideas about origin insertion, but they don't have an expansive way to kind of put it all together in the clinical situation. I noticed this with, the students that I had in New York a couple weeks ago, they of course know their anatomy. They're all therapists or trainers, and they knew some basic, their basic skill sets for anatomy. But I start listing relationships with like the diaphragm, the thoracic diaphragm, and when I mentioned the word cruce, they had no idea what I was talking about.
Mm.
They were missing two major components of the thoracic diaphragm for lumbar stabilization, and their faces went ashen.
Mm-hmm.
And they were so appreciative. You would not believe. And one girl in the class, she's just an incredible person. She was telling me how she took 4 different dissection courses, was a TA for dissection, and her mind was blown that she had never made the connections that I had helped her with, and she felt so confident going back and using her skills.
Can you give us an example of something that like a manual therapist could use in their practice that illustrates one of those connections? Or would it be part of a movement or part of a release technique?
We don't teach releases in immaculate dissection, although I do go through some ways that you can learn to palpate and just incorporate like pin and stretch and other types of techniques. But I try not to focus on the release. I try to focus more on the palpation. Because I find that a lot of people are skilled in knowing what to release or how to release, or they have their techniques that they enjoy, but they don't necessarily know how to palpate. So like I was showing them how to count ribs, how to find the 11th rib versus the 10th rib, how to find these major bony landmarks for different attachments of abdominal musculature, and they were so appreciative. I think that we don't, maybe only, I know for me, only in school did I really like have a responsibility to do that. After I was already a clinician and really using my skills, I didn't have a palpation course after that.
Pretty much left to your own devices for the most part.
You are! It stinks!
Never to be tested again.
Yeah, people just expect you to know everything after you graduate. What a bunch of hooey. I think that we need support after. It's okay to not know. And that's one of the most embracing things about immaculate dissection. One of the first things I say on the first day is, it's okay that you never made these connections before. You're not a bad person. This is just things that will help you be an even better palpator. If you're giving corrective exercise, it will help you to really help with your cueing patterns for those exercises and put the anatomy into a clinical situation, both with palpation, releasing, and with corrective exercise.
And you touched on the movement versus manual therapy. What you're teaching is suitable for both movement and manual therapists, or more manual therapy?
The personal trainer doesn't usually palpate. So, of course, I tell them you can't, if it's out of your scope of practice to be able to palpate your client, then of course, please don't say, oh, I took immaculate dissection and I can now palpate you. Of course, that this is more for an educational purpose of trying to understand where this anatomy is and how it's working. For the manual therapists that were in the room, they found it enormously helpful, of course, to palpate, and will be using those palpation cues every single day of their life. But the personal trainers I had in the room found it absolutely incredible, because when they took anatomy, it was very brief, very truncated probably, and then they came alive on the second day when we did correctives, and they were like, oh, this is how you apply the anatomy. So I never isolate the manual therapist. I really think that everybody could take this class, that you could bring in Joe Schmo off the street and be able to take the class and really get something out of it. My patients don't get out of it. They have to learn about their anatomy. Yes. I think we're humanly responsible to know about our anatomy. We wouldn't freak out all the time about every single ache and pain if we knew more about our anatomy.
Yes, that's very true, very true. How does Catalyst Sport fit into all this?
I own Catalyst Sport with my amazing colleagues, Jason Kapnick and Jill Boffey. They are incredible businessmen and just incredible trainers, and they were big inspiring forces behind Immaculate Dissection. Just conversations that we've had around Catalyst. Catalyst is the correct name for our place, because we definitely tend to catalyze each other and try to promote each other. But it's incredible. But they were where we premiered. We premiered it on January 10th of this year, and Jason and Joe had full confidence in me, which was amazing. And then 14 people came to this seminar. They had no idea what it was going to be. They had no clue, really. It was a brand new seminar series, and 14 out of 14 people gave me really solid, positive feedback. We've got incredible video testimonials that will be coming up soon. We're still, organizing them. But the written testimonials that you'll find on the Immaculate Dissection Facebook page, they're really good. And people really got something out of it.
So there only has been one so far.
There's only been one.
Okay.
Australia, I'm coming at you kind of new here, but I won't let you down. I have such a good time doing this. It was such a fun time. And it ran like a really smooth machine. Like, we had it really worked out. It ran so well. It was just a lovely experience. But don't worry about it being new. You're really going to enjoy it. It's something very special that you haven't experienced before.
I have no doubt. I've seen you in action, and I know that you have a deep, deep passion for what you do, and you have a deep, deep passion to teach other people it. So you cannot get a better combination than that. Day 1 versus day 2, you touched on there. What differentiates day 1 from day 2?
Day 1 is a great question. Day 1 is a lot of anatomy. We break out every single one of the muscles of the core concepts series. So basically all the abdominal musculature that's classified as core stability muscles.
What would they
everything
be?
from transversus abdominis. Oh, it's okay. Transversus abdominis, rectus abdominis, obliques, quadratus lumborum. I'm going to get you to look at these muscles in a way you never have. Each and every one of them, you'll have a light bulb moment that you're like, whoa, I didn't know that. To watch them scribble on their manuals, they were just scribble. They were so excited because they were like, what? I just didn't really make that relationship before. And then we move into palpation. So each section gets 20 to 30 minutes of discussion about the anatomy and palpation. And then we move very quickly into the next one. I think it moves with volition. Like any course, it can be overwhelming just because it's new and a lot of material, but they handled themselves very well at level 1 in New York. They did great. I don't suppose that Australia would be any different with that. On the day 2, it's all corrective exercise, everything from coaching quiet and tension breathing up to doing complicated skills like sledgehammer and hanging leg raise. We put the anatomy together to kind of understand what we learned the previous day and palpating different cues or palpating for different cues and putting the anatomy into a very functional setting.
Fantastic.
Yeah.
So could you give us a quick example of picking a muscle group and then the sort of information that you'll go through with it?
Sure. I'd love to. One of the biggest hits, I think, of the seminar series was the thoracic diaphragm. So we talk about the thoracic diaphragm not just as a breathing muscle, but as a lumbar stabilization muscle. So I go over all the attachments and how the diaphragm helps with cueing patterns for the rest of the abdominal musculature to fire, especially in exhalation. And we go over palpation of that via the crura and medial and lateral arcuate ligaments. The median's a little tough to find. I'll tell you about that at the seminar. But we go over different relationships with the diaphragm that people forget about, like hiatal hernias and pulsating aortas and low back pain. Diaphragm is a huge component in low back pain, and it often gets forgotten about. And I'm like, hello, it attaches to 3 lumbar vertebrae. Hi, this is a very important anatomic connection to back pain. And so when you're teaching breathing and it becomes very esoteric, and breathing is one of the most important low back stability drills, you have the anatomy in front of you to show the client or show the patient and say, look, look at this. Look at this manual. Look at this drawing. This is a very important connection here. And then the patient's face is like, I had no idea. And I'm like, I know. This is why I'm trying to teach it to the world. This is important. This is what's getting missed. People are getting injected and constantly get surgery put upon them, and really they need some quality manual therapy and quality training. And so I reiterate that with the correctives. So the next day we do breathing, and I coach breathing on how to properly cue the diaphragm to get it to work in good anatomic position. And the cueing patterns are really important. We talk about the connections of the neck to the diaphragm, because it's innervated by the diaphragm, or the diaphragm's innervated by the neck. And the positioning, like I think one of the biggest bangs of feedback I got was, holy cow, I've been doing all these exercises, but I didn't cue it properly. And so when you see the list on the website of all the exercises, you're like, oh, I already do planks, or I already do crawling, or I already do rolling patterns. You might find that you have some definite nuances upon which you can improve.
You can also, everyone that's listening, if you go to Kathy's website, drdooleynoted.com, or her YouTube site, there's a ton of videos. I don't know how many there is. Got to be in the hundreds, and as well as posts and ideas and thoughts about anatomy and life. What do you like most about the course? What do you think is the essence of it?
Me, what do I like best?
Yes.
Or what do I think the students like best?
No, you.
I completely geeked out, I have to admit. When Anna and Eric Chesson, our sponsor from Stronger Than You, we had them both painted, of course, for the abdominal musculature. And putting them through the motions and watching the anatomy like shorten on the body and then lengthen on the body, their eyeballs almost popped out. They were like, whoa, you can really see what internal abdominal oblique does for rotation, or oh, you can really see how the diaphragm is connected to the psoas. That is incredible. Their eyes were amazing. I had such a good time that I was almost shaking, Jeff. It was ridiculous. Like I was having so much fun that I could have been a kid in a candy store. It was definitely just the most amazing experience to watch the anatomy come alive in these attendees. They were just, wow, they saw the anatomy at work, which you don't get to see very much. You don't get to see, you're kind of picturing it in your head. You're not seeing it in front of you, like with rotation, with flexion, with breathing. They really enjoyed it, I think. And I know that, I can't speak for everybody, but for me, I was geeking out. I've seen it a million times, and still, with Danny's amazing artwork, it was just an incredible thing to see on the body like that.
Okay, so that's once that picture that we've got on the screen at the moment with Anna's got the extensor compartment on there. So when she's moving, you're getting an idea or a visual of what the muscles are actually doing. Is that what you're saying? Okay.
Yeah, like for instance, one of the highlights is when Anna and Eric were rotating, and you could see the fibers of, let's say they were rotating to the right. You could see the fibers of the external abdominal oblique on one side, and the fibers of the internal abdominal oblique on the other side actually shorten. Like you could see that you can see their attachments, and then you just watch it all happen, and you're like, whoa! It's just really fascinating to see that, and it reaffirms what your knowledge is. And some of the feedback I've gotten afterwards was that, wow, I had the manual out and with a patient and with a client, and I could really see it in a different way. You can actually visualize it now that you've seen it work. It's like you can't unlearn that.
So that would be particularly the value for movement therapists as well, if they can actually visualize.
Oh my! Oh, if you can see someone, like I want people to see what I see. That's the whole point. Like I see you in 3D because I've dissected so many times, and so I'm looking at that person. I don't want to be macabre, but I look at that person as if I can see their anatomy from the inside. And when you do that, it makes the whole thing a lot easier to diagnose in my case, but easier to see what's missing or what may not be moving well. And that knowledge is something that is so helpful as a clinician, as a trainer. Oh, they don't approach that plane. They don't get into that place. Or, oh, maybe I can help them earn some more flexion here. It's extremely valuable.
Well, having seen so many people in the lab, I do recall you saying that there's a couple of misconceptions that people have.
I guess something we talked about at Core Concepts a few weeks ago was some of the misconceptions that happen with hernia. We talked a lot about hernia, and I was very shocked that I had a room of very qualified clinicians, and they were they were really not sure about the mechanisms of inguinal hernia, ventral wall hernia, umbilical hernia. We all kind of know that they happen, but
Yeah.
we don't understand some of the mechanisms. And so I started talking about the rectus sheaths, and we started talking about the relationships of building pressure in the abdomen. And I hope they left with a really great understanding of not only how to treat hernia or help with hernia, or if you have a client with a hernia, how to modify a program to help minimize the discomfort, but how to prevent hernia. That is huge. And we focused quite a bit on that because it's a huge, huge clinical finding in the abdomen.
And more common than we would expect?
Very common. A lot. I mean, the anatomy itself makes it very susceptible for you to have hernia. It does it on purpose, so you don't build faulty movement patterning. That's why you have so many bursae around your knees and elbows and shoulders. It isn't what you're using them all the time. And why you have no bursae at your trunk, at your core musculature. The fact that we are meant to really drive and pull a lot of force in through the abdomen. It's flat muscles except the psoas. Almost all the muscles are very flat, very thin, built for a ton of endurance, a ton of force, and that's important to recognize.
And during the course, do you go through planes that muscles travel through? So like the trunk not being isolated from other muscles, but how that feeds into the shoulder girdle and down through the hips and across the glute max and the like?
Of course, we keep it pretty minimal as far as force distribution, just because of the time constraint, and we want to focus on palpation. But I can't avoid having those discussions because it's so important. So yeah, we do talk about force transfer a little bit, and we talk about different planes of movement. Of course, you have to when you talk about action. If you're going to list actions of muscles in concentric or eccentric contraction, then you have to list the planes upon which they move and how they affect the adjacent musculature and joints. So because I could talk about the thoracic diaphragm for an entire seminar series, I have to keep it truncated and really abbreviated more than I would personally like. But the beauty of that is that you have a question, you post it on the Immaculate Dissection Facebook page, and then we start discussions about the anatomy that haven't been had before. I'm all about Immaculate Dissection being not only progressive but malleable. Like if I find that people are finding more connections with things, or maybe I'll find more connections with things, Immaculate Dissection will grow. I've already got requests, man. People are really motivated. They're like, I want an entrapment series. I want you to talk nerves and arteries. I'm like, okay, all right, we'll get there. Let's start with core concepts, and then we already have lower extremity planned, and we're in the works of building that manual now. And then upper extremity. It's all coming, folks.
Oh, fantastic. If anyone does have a question they'd like to ask Kathy about the Immaculate Dissection seminar, you can just type it into the screen on the left-hand side, and we'll try and get to as many as possible. One of the questions that has come through, Kathy, was who is it suitable for this course? Is it more beginners or advanced or?
Oh, that's a good question, too. I think that's hard to say just because the word advanced to me can mean different things. I had very seasoned manual therapists, really, really good chiropractors and movement specialists in New York. They had got so much out of it. I had someone there that teaches anatomy to massage therapists, and she had told me that she learned several new things that she's going to apply just off the first day. And I think that anyone who's interested in trying to understand some of the correctives they do or exercises that they do or that they assign, as well as people that palpate. I think that I had people there of very different levels, and they all got something really strong out of it. I don't think that it should be discouraged from beginners from taking it. In fact, if this were my first anatomy course, I would have been better off. I really promote students take it before they become clinicians, but for the clinician that's been out for a while and is really experienced, I had a chiropractor there that's been a chiropractor for many, many, many years, and he got so much out of it. He was just telling us afterwards how it really helped his other techniques click. He's a brilliant manual therapist, more skilled than I at manual therapy, I'm sure. He's done it longer. And he was telling me how much he got out of it. So I think it's for beginners in a different way because they're exposed to the anatomy in a very functional way that's not as textbook, if you will. And it helps with the textbook. It helps with the understanding of how things are connected.
Kerry's asked, can you really palpate external oblique and internal oblique separately?
Absolutely, you can. Absolutely, you can. What you do is you find the bony landmarks and you start to move the patient, and you start to be able to palpate that by knowing what things do, and then feeling them move. Of course. I mean, let's be real here. You're only feeling skin, okay? We know you're only feeling skin, and that's where the vast majority of your proprioception is anyway. We know you're feeling skin, and these are all very much concepts, which is why it's called core concepts. But, when you're doing a manual release on the psoas, no, you're not. So if we're being very literal here, yes, this is about learning relationship patterning, and when you do release work, helping to promote the movement of fascia around tissues, and by knowing where these things are located and learning how to, I'll put palpate in quotes, it becomes extremely helpful in your treatments to be more effective if you can learn the anatomy and how to palpate it. The only one palpating the external abdominal oblique is people like me in the lab, where all the skin is off. Yeah, and let me tell you, that is not even as valuable in a lot of ways as learning what it's like on the body with the skin off, because that's when you can actually create change. Once they're on my table, I can't create change. I mean dissection table, by the way. Once they're on the dissection table, I can't create change. I can create change if they're right in front of me in vivo.
Question from Rachel here. Do you cover the relationship of movement to the muscle that need to lengthen as opposed to shorten? And those
we do.
Yeah,
we do. It's really just the opposite. I think that I understand Rachel's frustration because they only talk about in textbooks usually concentric contraction, just because they assume that the opposite would be eccentric load. But we definitely talk about eccentric load.
Peter's got a question here. Are there any diseases related to musculoskeletal dysfunction patterns that you are shown in class, or ones that you can talk about, or the ones that you've seen in the lab?
Of course, there's many I've seen in the lab, but we don't focus on the neuromusculoskeletal disorders in this because it's a beginning course on core musculature. But when it comes to fascia and muscle quality, disease processes like cancer, like scleroderma, psoriatic arthritis, multiple sclerosis, cerebral palsy, these things absolutely change muscle tonicity and the fascia around it, and the way that proprioception's put into the system. So I think that absolutely disease processes matter, but we don't focus on it as much. We do cover things here and there, but no, I would say that this is not a course you'd want to take if you're trying to learn disease processes and how it affects anatomy.
I know Peter who asked the question. It's probably more from a point of view of we often feel different tissues under the skin, and I guess if there was any sort of, if you could see anything, was what he was getting at, I think.
Oh, okay. As far as from the outside, you might feel bubbles and hardness, and cancer likes to form non-movable nodules. Versus, lipomas that are a little softer and benign. So we don't cover a lot of that, but if we do find it, we'll talk about it. The breakout labs, but, in the cadaver, yeah, you see that all the time. I don't go a day without seeing disease processes and the way that it can invade upon the anatomy.
How many people have lipomas?
Oh, almost everyone.
Yeah?
They're completely benign. It really is just a strangulation of the fascia around fat, because you, especially around the midsection, but you have 2 layers of superficial fascia in the midsection. So you only have one in the rest of the body, and the superficial fascia is fatty. So as people move and twist, you can actually twist some of the tissue, and then this lipoma is born. And they're completely benign and very alarming, because when you palpate, it's like, I've got a big bubble here. Not that I'm suggesting that everyone go in for surgery. If you did an incision and cut it out, you'd be no worse for the wear.
Mm.
But when someone develops lipomas, I kind of wonder if they don't have movement dysfunction in the surrounding area. Because
Yes.
that's
Makes
why
sense.
they have the lipoma in the first place. It's
Yes.
because they're twisting in a weird way, they're turning in a weird way, and the fascia has actually wrapped itself around a piece of fat and made it, very much apparent underneath the skin.
Okay. Sarah's got one question here. We'll make this the last one. Will I be smart enough to learn all this?
Of course you will. This is not a This is not a course. Is it Sarah? Is that what you said?
That's right. Yes.
Sarah. So
In
Sarah,
Queensland.
Sarah, this is a course that you will leave smarter, definitely, than when you came. That's the whole point. You will leave with such a command that it will be very inspiring. We always come full circle too. I think one of the best teaching techniques is repetition. And so I'm constantly going to make you feel responsible. I absolutely will call you out and make you uncomfortable because that's the way you learn. But I do it would be in a very encouraging manner. Will you not feel browbeaten? I promise. Of course you're smart enough. Anyone is, and that's the whole point. Is for me to be able to teach anyone off the street some anatomy, and I do it every day of my life. The majority of my patients are not manual therapists. They're in finance or they're in some other job, and I think it's really important for people to know their anatomy and how it works. I think you'll do fine. I think you'll do great. And if not, I'll find you and I'll help you.
There you go, Sarah. That should be satisfying. All right, just to wind up, Kathy, I've got 6 quick questions that have nothing to do with anatomy. They're all about Dooley.
Oh, okay.
Favorite color?
Favorite color is definitely blue, like a royal metallic blue.
Okay.
Catalyst blue.
Catalyst blue.
Yes.
Your favorite country that you visited?
Oh, I'm going to say Australia. But that's technically country and continent, right? So
Very
you
true,
get like 2 wins. Australia is the most beautiful place in the world. I mean, the apostles, like when we went to see that, my friend Jenny Richardson, she's amazing. She took the time to drive us all the way down Great Ocean Road, and I got to see, oh man, that was the most beautiful thing I've ever seen in my life. I can still see it like it's in the room with me right here in New York. It's like, oh, amazing.
Your favorite food?
Oh gosh. That is so hard. I have to pick one?
Mm-hmm.
Oh man, I couldn't live without it. Probably mushrooms.
Your first car?
Oh, a hunker junker. Don't tell my parents I said that. Oh no, this is on the internet. A Ford Capri. Do you even know what that is? Does anybody know what that is?
Yes.
It was it was so great. Such a great car. Really let me crash it a couple times.
Favorite movie?
I have to pick one. This is so hard, Jeff. I usually I pick between 2, American Beauty and Almost Famous. I probably would say Almost Famous is my favorite.
Okay. And favorite book?
Oh, man. I really, really liked The Mighty Atom.
Mm-hmm.
It's about Joseph Greenstein. He was a strong man. That's one of the most inspiring books I've ever read. But I want to say, like, Grey's Anatomy, I've fallen asleep with it in my lap before. So it's probably an anatomy book. I've read anatomy a lot more than I've read Mighty Atom. So the best book that's not anatomically related would be Mighty Atom. But I'm looking right here at my desk, and I've got an anatomy book and Chateau's Chronic Pelvic Pain and Dysfunction. So those are hits right now. Anything anatomy related, definitely. But Grey's, if you don't own British Grey's, it's an amazing investment.
If you're down to your last $10, how would you spend it?
Oh gosh, last $10? I don't even know. Like, money is not a huge motivator for me. I grew up poor, and I could just as soon be poor and be fine. Last $10, probably anything that gets me close to an anatomy lab or gym. You can work out without a gym though, so. Probably begging somebody to let me in the lab to dissect.
Thanks so much, Kathy, for taking the time out this morning. The slide that we've got up on there is Dr. Kathy Dooley, Immaculate Dissection Seminars. They're coming to Sydney and Melbourne in March this year. So if you take a look at drdooleynoted.com and go to the Immaculate Dissection page, all the details are on there. Kathy is a bubbly, vibrant, intelligent, wonderful person. and just going to see her is worth the price of admission alone. So
Oh,
if you if you have the inclination, forward to seeing you there. So thank you once again, Kathy, for taking the time out and getting up at 4:30 in the morning to speak with us. And
it was my pleasure. Sorry if I stumbled a little bit. I'm definitely out of practice being up this early. So thank you for tolerating me today. But thank you, Jeff. Wow, that was such a nice accolade, and I always enjoy these talks with you. It's like talking with you across from your dinner table. It's nice.
Yes, well, the girls are looking forward to you teaching them the next phase of pistol squats as well around the dinner table.
Yes, pistols. I love those girls. You have an amazing set of women in your household.
Well, thank you very much. Well, on with our days, everyone. Thanks again, Kathy. We'll see you real soon. And thank you, everyone, for tuning in.
Thank you, Jeff.